Hi friends, let's have a look at this short case scenario where there is a young patient who complains of painless bleeding per annum and also protrusion of a mass-like structure through his anus at the time of defecation. This mass reduces by itself once the act of defecation is over. So what is the most likely clinical diagnosis and how we are going to manage this patient? What is his main concern, his main worry is that he is worried for this mass. He thinks that this mass may be a malignancy. So regarding this case scenario, as the patient is young and he is also having a very typical history that there is a mass which protrudes out at the time of defecation and it goes inside, and also he is having a painless bleeding. So this goes in favor of a very common condition known as hemorrhoids. Now why it should not be a malignancy? It's not a malignancy most likely because of the young age of the patient, one, and the second, a very typical history of reducible mass. If this mass would have been a fixed mass which is lying outside the anal canal, I would have thought about malignancy. So what are hemorrhoids? Hemorrhoids are actually normal vascular cushion present inside the anal canal at three positions: right anterior, right posterior, and the left lateral position. This becomes pathological when these vascular cushions descends from its normal position because of chronic straining, because of the chronic constipation, because of the aging, and this gives rise to a clinical condition we known as hemorrhoids or piles. So what is the clinical presentation? The clinical presentation may be just bleeding, which is usually painless, or bleeding with a protrusion of mass. So we have actually graded this presentation of hemorrhoids into four parts. The grade 1 only bleeding, grade 2 bleeding with protrusion of mass which reduces by itself. So this patient, our patient, is having actually a grade 2 hemorrhoid. Grade 3 is this mass has to be reposited back with the help of his hands. That is grade 3. And grade 4 is which is permanently lying outside. So these are actually the four grades. Now there is another classification of hemorrhoid, that is internal hemorrhoid and external hemorrhoid. This depends on the location of the hemorrhoid. If the hemorrhoid is above the dentate line of the anal canal, it is known as the internal hemorrhoid, and if it is below the dentate line, it is known as the external hemorrhoid. Now as we know that below the dentate line, it is actually sensitive to pain. And so how we are going to investigate the patient of hemorrhoid? So first we have to do the physical examination. So in the physical examination, we need to do the three things. First is the local examination of the anus. Second is the parietal examination, and third is the anoscopy or the proctoscopy. In the local examination, just by inspection, we can diagnose grade 4 internal hemorrhoids, which will be lying outside, or it may be an external hemorrhoid which is lying outside, or even it may be a prolapsed painful hemorrhoid which is lying outside. Sometimes there may be difficulty in diagnosing between hemorrhoid or grade 4 hemorrhoid with prolapse of the rectum. In the prolapse of the rectum, you will find the typical circular folds, one, while in the case of internal hemorrhoids, which is grade 4, you will find the three typical locations with radial folds. That is, can digital rectal examination diagnose internal hemorrhoid? Answer is no, until unless it is scarred, because the hemorrhoids are just the vascular cushions. The moment you put the fingers inside, the blood will disappear and you may not find anything. But if it is scarred, if it is thrombosed, you will be able to feel the hemorrhoid on the parietal examination. We basically do the parietal digital examination to rule out any other disease like a malignancy, like a growth. Now coming to the anoscopy or proctoscopy, this is the best investigation to diagnose an internal hemorrhoid. Sigmoidoscopy or colonoscopy is usually done in a patient who is old, just to rule out any other coexisting disease. Now coming to the management. The management will be the early stage and the late stage. Early stages can be just managed by the conservative management, and the constipation needs to be taken care of, like by giving the laxatives. If you want to do any procedure, if somebody is continuously having bleeding, there are two options to be done in the early stages of the hemorrhoid. That is the injection sclerotherapy, where a sclerosant is being injected into the hemorrhoid tissue, which is done on an OPD basis. And the other option, which is very famous, is the banding. The banding procedure is you apply a band over the internal hemorrhoids and this hemorrhoid sloughs off. The only issue with the banding is sometimes patient goes into the sepsis. So we need to tell the patients about the features of this sepsis, and if the patient develops post-operative fever, he should report immediately. Coming to the operative management. When the patient has these conservative measures which are failing, or there is recurrent hemorrhoid or external hemorrhoid, in those cases we need to do some surgical intervention. The surgical interventions That is, haemorrhoidectomy means excision of the hemorrhoid tissue. It can be done under two settings. One is open haemorrhoidectomy, where the incision is just left open to heal by itself, so it takes some time in healing. And the other is the closed haemorrhoidectomy. In the closed haemorrhoidectomy, the incision site is closed. Now there is a third option which is very famous nowadays, and that is with the use of a stapler, and that is known as stapler haemorrhoidectomy. And this procedure is also known as PPH in a common term, and that is the procedure for prolapsed hemorrhoid. So this is all in short about hemorrhoids. Thank you.